AI tools are now part of the standard screening mammography workflow, used to triage exams and classify potentially suspicious lesions. In the United States, patients are accessing these results more directly than ever before. Federal policies like the Cures Act have accelerated the push for open notes and digital portals, placing raw medical data directly in the hands of the patient. This shift is driven by a specific industry assumption that providing raw AI telemetry to patients will build trust, increase transparency, and lead to more empowered healthcare decisions. However, injecting raw AI data into a portal alongside human clinical reports creates a new friction point, one that risks complicating the patient experience by presenting data they aren't equipped to interpret. To test this, researchers at Brown University conducted a randomized controlled trial involving over 1,600 patients to observe how they react to seeing AI results in their portals. Every participant in the trial was shown a baseline scenario, a standard report from a human radiologist that was negative for breast cancer. But for most of these patients, the portal also included an AI abnormality score, ranging from a score of 0, which suggests no suspicion, to a 50, which indicates the algorithm has flagged the case. The top-line results revealed that exposing these raw scores triggered significant increases in patient anxiety, a higher demand for unnecessary follow-up care, and a greater willingness to pursue medical malpractice litigation. This suggests that transparency without statistical context acts as a clinical hazard. It provides patients with a metric that can be weaponized against the interpreting physician. The study also found that a specific method of statistical framing could almost entirely neutralize this effect. When integrating AI into the clinical workflow, the way the algorithm's output is framed for the patient is as critical to their safety as the accuracy of the algorithm itself. To measure legal risk, the trial asked participants a difficult question. If a clear report was given today, but advanced cancer was discovered a year later, would they consult an attorney to sue that original doctor? In this chart, the red dashed line represents the control baseline. Even without AI involved, roughly 40% of participants indicated they would consider a lawsuit if a human radiologist missed a cancer. Then the researchers looked at what happens when the patient portal includes an AI score that flags an abnormality, contradicting the human doctor's clear report. Looking at the flagged abnormal section, that litigation intent jumps from 40% to over 60%. Seeing a discordant machine score significantly increases the desire to sue the human radiologist. Designers often try to mitigate this by adding a numerical cutoff threshold, essentially telling the patient that any score above 30 is considered abnormal. But the data shows that the threshold does not help. Litigation intent remains elevated, staying well above the baseline for patients who saw those scores. These numerical thresholds seem to function as danger signals. Instead of providing context, they provide the patient with perceived evidence that their doctor missed a machine-verified finding. These psychological shifts translate into immediate changes in patient follow-up behavior. This chart tracks the demand for a second opinion from a different radiologist. The line climbs sharply when AI scores and thresholds are introduced. With a threshold, the desire for a second opinion spiked to 80%, even when the AI and radiologist agreed. The researchers noted that these behavioral changes could increase clinical volume and healthcare expenditure for procedures that offer no diagnostic benefit. This mountain peak pattern repeats across the data. Whether patients were demanding a meeting with a primary care physician or more accurate follow-up imaging, the introduction of thresholds caused a similar spike in demand. Providing a simple numerical threshold backfires. It can transform a healthy negative screening into a source of active diagnostic panic for the patient. To solve this, the researchers introduced a statistical variable that is almost always missing from these portals, the false discovery rate, or FDR. In clinical terms, the FDR represents the mathematical probability that an abnormal flag from the AI is actually wrong. Because screening tools are highly sensitive, they flag many benign findings. For the algorithm modeled here, the false discovery rate was a massive 95%. Watch the litigation data again, but this time, observe what happens when that 95% error rate is explicitly shown to the patient alongside the score. The threat is neutralized. Intent to sue plummets below even the original 40% control baseline. Stating the error rate provides an immediate check against the false certainty of the AI's abnormal flag. This same neutralizing effect occurred across all clinical behaviors, instantly reducing the demand for unnecessary secondary imaging and PCP consults. Contextualizing the fallibility of the algorithm doesn't confuse the patient, it helps immunize them against mathematically induced panic. Why is showing a 95% error rate so effective at calming patients down? It leverages a psychological concept known as algorithm aversion, the human tendency to lose trust in an automated system the moment its errors are made clear. The trial data shows a consistent preference for human judgment. Trust in the radiologist, represented by the blue line, was higher than trust in the AI across every experimental condition. Despite that preference, a raw AI score creates just enough ambiguity to inject doubt into the doctor-patient relationship. By explicitly stating the high false discovery rate, the portal provides the patient with the information they need to dismiss the machine's flag and trust their physician. Honest reporting of AI error rates is a necessary tool to preserve patient trust in human clinicians. These results provide a roadmap for how hospital systems should design their digital interfaces. Providing data transparency without statistical context can violate the clinical mandate to do no harm. Emerging regulatory frameworks are beginning to reflect this. The FDA's Good Machine Learning Practice Guidelines now emphasize that users must have access to contextually relevant information that is appropriate for the audience. For any patient-facing AI module, there is a mandatory triad of information. First, the raw AI score. Second, the numerical cutoff threshold and the corresponding error rate. A safe interface translates the data for the patient, clearly stating, "Note, algorithms at this sensitivity have a 95% false discovery rate. Your radiologist's clear finding remains the definitive diagnosis." This structure protects patient autonomy, while simultaneously shielding human doctors from unearned legal and clinical liability. True transparency isn't just dumping raw data into a portal. It requires engineering the interface so that data tells the statistical truth.